And so my presentation is on the most important barrier faced by premature infants that we take care of in the neonatal ICU, that is the appearance of late onset sepsis. This is the most significant complication that's faced by these babies beyond the first week of life. And the scope of the problem is staggering. We know from data, NICHD network data, that 1 in 4 extremely preterm infants will suffer from at least one episode of late onset sepsis. And for the babies that are suffering from late onset sepsis, the mortality risk is as high as 20 to 40%. The higher number applies to babies that are being taken care of in the resource-limited parts of the world. And even the babies who survive are not always lucky. They face a 50% increase in the risk of long-term neurodevelopmental impairments. And interestingly, this risk applies to babies with both culture-proven sepsis and also culture-negative clinical episodes of sepsis. And one of the major challenges that we face is that early diagnosis of late-onset sepsis is extremely difficult. So if we look at the progression of a premature baby in the neonatal ICU, even though the premature baby is rocking along and physiologically stable, and then if that baby acquires infection silently, this leads to what is known as systemic inflammatory response with release of cytokines. And this is the point when baby develops non-specific signs of illness, such as increase in apneic episodes, worsening of the respiratory status, or temperature instability, et cetera. And this would then alert the clinicians to proceed with drawing lab values such as CBC with differential or blood culture, and then initiate antibiotics. But these babies often continue to progress because of cytokine release to develop hypotension and require ventilator support. And as I already mentioned, one out of these 3 infants will go on to die. So emerging evidence over the last 20 years suggests that these babies display signs of autonomic dysfunction, which would then be reflected in decrease in the heart rate variability. So perhaps this function gives us a window of time when we could intervene and initiate these same interventions, such as drawing blood cultures and initiating antibiotics and other supportive measures that could perhaps lead to improved outcome and decrease in the mortality risk. So we have known for many years that heart rate variability can give us an idea of the well-being of the baby. And so we have been learning this system through extensively used fetal heart rate monitoring, and this has been in place since the 1970s. So in fetal heart rate monitoring, and I'm going to show you an example in this slide. So normally, the fetus shows tremendous beat-to-beat variability, which accounts for the squiggly line when you look at the fetal heart rate trace. And this is due to alternating input from the sympathetic system, which picks up the heart rate, and the compensatory response from the parasympathetic system, which then brings the heart rate back down to normal level. And this accounts for this squiggly line. And there are also periodic accelerations and decelerations to this fetal heart rate tracing. Now, if the same fetus gets hypoxic due to cord compression, that heart rate trace becomes relatively smooth and flat. This indicates loss of beat-to-beat variability. And also this fetus then begins to develop periodic deceleration as the parasympathetic system takes over the regulation of the heart rate. So if we think of the premature newborn is nothing but a fetus that's being supported artificially in the neonatal ICU. So we could expect that the premature infant would display the same type of fetal heart rate variability that can be picked up on the bedside monitor. So I'm going to show you this example. If I can draw your attention to the top left panel, or panel A, this is the heart rate tracing that's acquired and compressed over a 20-minute period for a 28-week gestation baby that's physiologically stable. So again, you would appreciate that there are up and down oscillations to this the heart rate tracing, suggesting that there is alternating sympathetic and parasympathetic influences in this baby. Now, the same baby then subsequently went on to develop sepsis. And a few hours before the clinical appearance of sepsis, you begin to see the loss of heart rate variability. So this heart rate tracing becomes rather smooth and flat. And then a few hours later, this heart rate trace begins to show numerous transient decelerations. And these decelerations are not deep enough to trigger the bedside bradycardia alarm on the monitor. So the lowest heart rate point is around 125 beats per minute. So if you take a segment of this heart rate tracing and spread it over a 5-minute time period, you begin to see this sinusoidal pattern. So we could recognize it on the bedside monitoring, but the challenge is that this is highly subjective. And this also depends on the experience and training of the personnel that are at the bedside monitoring this baby. So what if we can take the input and then apply the statistical principles to develop an algorithm that would give the bedside clinicians a simple number that would represent a fold increase or decrease in the risk of infection. That would be of tremendous value to the clinicians, because this will be a simple number that we can look at and understand that the babies are at an increased risk of sepsis. So we can do this by taking the signal and apply 3 statistical principles. So for example, in the heart rate tracing that I just shared with you, if we plot all the data points from a 20-minute spread into a histogram, we begin to see that these data points fit into a nice bell-shaped curve. And there are 3 important properties about this bell-shaped curve. First of all, the standard deviation is going to be large because of the high variability of these measurements. And secondly, there is a lot of symmetry to this measurement. So this symmetry comes because the data points are equally spread on either side of the mean or average. And there is also wide base because these data points have long tails. So there are many measurements that are below and many measurements that are above the mean. So this gives large entropy to this histogram. So those are the 3 characteristics: standard deviation, symmetry, and entropy. So if we take the example where the baby has started to get sick and begins to lose the heart rate variability, notice that the numerous decelerations give this histogram a sort of asymmetry, because most of the data points are now going to be on one side of the mean. And this also leads to decrease in the standard deviation and also narrowing of the base, so smaller entropy. So we can take these 3 statistical measurements and compress that into one simple calculation called HRC index. And you don't need to worry about the formula, but this HRC index will integrate these 3 measurements and represent the risk of infection as a fold increase or decrease from the baseline. So this HRC index then gives you an idea of the upcoming or impending risk of infection for the baby, hopefully about a few hours or a day earlier than the clinical appearance of the signs of infection. So I'm going to show you a couple of examples on individual babies. So this is HRC index that's being displayed on a commercially available monitor called the Hero monitor. And I just want to disclose that I have no connection to this company. So I'm going to just share with you my experience. So this is a display that is from a 28-week gestation preemie. And this display is shown for 4 different days, 4 consecutive days. So over a 2-day period, the HRC index that is shown here is below 1, representing low risk of infection. And then at the vertical green line, this baby began to show clinical signs of infection. And this led to drawing of the blood samples for culture and CBC and initiation of the antibiotics. But if you look at the HRC index tracing, for about 24 hours before the clinical signs of infection, this HRC index rises to number greater than 2, suggesting that there was a window of opportunity when we could have intervened sooner. And the corresponding heart rate trace is shown here, showing baseline variability that was fairly normal, and then transient decelerations appear 24 hours before the clinical signs of infection appear. So there is another example that I want to share with you. These are from 2 different infants. The first one is a term infant. This baby had initiation of culture, resuscitation, and administration of antibiotics at this point. And if you look at the week before the clinical signs of infection appear, there are spikes in the HRC index over 3 consecutive days. So this is a time point when we could have intervened to initiate this same workup and administer antibiotics. And this baby developed a staph bacteremia, and that's why the baby was getting sick. And the second example is a premature infant born at 28 weeks of gestation, again got sick and was recognized by clinicians, and this led to same thing, cultures, resuscitation, and administration of antibiotics. And if you notice the HRC index, for about 1 week prior to the onset of clinical signs, there are actually a couple of spikes in the HRC index, again giving us a window of opportunity for intervening in this baby. So moving on to larger data set, there was actually a very nice observational cohort that was collected from University of Virginia, and also a replication cohort collected from the Wake Forest University. And this observational data set consisted of 750 very low birth weight infants, and this group of infants had a total of 150 episodes of culture-proven sepsis. So what I'm showing you is the HRC index scores, and also the traditional measures of clinical illness scoring, and also laboratory parameters. And the time zero indicates the time point when the babies became clinically symptomatic and had cultures drawn and antibiotics initiated. And the data for HRC index are shown in these open rectangles. And if you look at the timing, the spike in the HRC index begins to appear 24 hours before time zero. That's when the babies began to get sick. And the clinical signs and the laboratory parameters of sepsis coincided with time zero. That's when the antibiotics were started. So suggesting that in this large data set, HRC index obtained from the 750 babies, spike in the index preceded by 24 hours the appearance of clinical signs of sepsis. If you look at the individual odds ratios that are calculated for HRC index, and also the traditional measures of clinical signs and also laboratory parameters, notice that the HRC index that is shown at the top actually outperformed the other traditional measures of clinical sign predictors. And also in this study, the HRC index not only was independently predictive of sepsis, but also contributed to the predictive ability of the traditional measures of clinical signs and also laboratory parameters, increasing the ROC area under the curve from 0.6 to 0.75. So HRC index data can contribute to prediction of clinical signs of sepsis. Now, I would just want to share with you the answer to the pivotal question: does HRC monitoring information actually improve the clinically important outcomes for babies that we take care of in the neonatal ICU? So this question was addressed by a large randomized control trial that was done from 7 different large neonatal ICUs in the US. And in this study, let me just show you the study design very quickly. This is a multi-center RCT. In fact, the largest randomized control trial done in premature infants in the post-surfactant era. So in this study, half of the babies were randomly assigned to a HRC intervention group. In this group, the HRC index information was made available to the bedside clinical team, and then the bedside clinical team were free to make their own decisions. So no specific actions were mandated by the clinical team, mandated for the clinical team. In the other half of the infants, the HRC characteristic information was shielded from the clinical team. So the primary outcome measure for this study was survival of the babies free of ventilator support for the 4-month period after the enrollment into the study. And the secondary outcomes are length of stay in the hospital, number of days on antibiotics, and the in-hospital mortality risk for these babies. So there were a total of 6,000 babies that were screened for the randomized control trial enrollment, and half of them, or 3,000 babies, were actually randomized into the trial. The most important reason babies were excluded from the study was decline of consent by the parents. So out of the 3,000 infants, 1,500 were assigned to HRC display group, and equal number were assigned to HRC results being shielded from the clinical team. So let me get to the results of the study. So I'm going to show you the primary outcome data at the very top. So the number of days alive and free of ventilator support were different between the HRC display group and the control group. So on average, HRC display, information display improved survival free of ventilator by 2 days. And that's significant improvement. And the p-value was 0.08. So when the study was published in Journal of Pediatrics, this was cited as a negative study, but in my mind, this is a positive benefit. Basically, these results imply that there is a 92% chance that the difference between the two groups is not due to chance. They also observed that there is a significant decline in the mortality risk for the group that had the HRC information displayed. And the subsequent data analysis revealed that this decrease in the mortality risk was primarily due to decrease in the mortality risk for the extremely low birth weight infants, those babies that weighed less than 1 kilo. And looking at the sepsis-related mortality risk, there is a striking decrease in the sepsis-related mortality risk for the group that was assigned to the HRC display. So if you look at the results more carefully, in the control group, 16% of the babies that had culture-proven sepsis died. In comparison, only 10% of the babies in the HRC display group died. So this is a 36% relative reduction in the mortality risk. So this is the most important observation from this study. So to summarize these results, displaying the HRC information decreased the mortality risk for the extremely low birth weight infants, and the number needed to treat is 23. So for every 23 babies that had the HRC monitoring done, 1 life was saved from dying as a result of complications of sepsis. So from these results, we could speculate that HRC characteristic information being made available to the clinical team leads to earlier detection of sepsis, and this leads to earlier intervention and a decrease in the overall risk of mortality. So these are my recommendations to you. I think you should really assess the background sepsis incidence in your own unit. If your incidence is less than 20%, congratulations, you don't really need to do anything else. You don't need an additional tool. But for the rest of us, I think we really need to look at the availability of NICU staffing and 24/7 availability of the lab tests. And I think HRC characteristic information could be a useful trigger to you to examine the babies more carefully when the risk of infection rises, as indicated by this test. And I think you really need to track the use of invasive lab tests and also antibiotic use to make sure that there's no therapeutic drift when you use this tool. We need to ensure that we're not doing unnecessary lab tests and giving more antibiotics than necessary to these infants. In this large randomized trial, there was no significant difference between the treatment, between the intervention group and the shielded group with respect to number of lab tests done and antibiotic days. So finally, I just want to share with you a picture that I have taken 2 years ago. My son and I went to do a backpacking trip around the mountain, majestic mountain, Kanchenjunga. And no matter how far we walked, it seemed like the peak was always as far away as when we started the journey. But we did make some progress, so that's where we are. I think we're making progress in our ability to monitor these infants for signs of infection and in decreasing the mortality risk, even though the peak seems just as far away. Thank you very much for your time.